Thank you, Dr. Christopher Runz, for talking to the world about common urology problems that might face a general surgeon.
Oh, it's my pleasure to be here.
So tell me, if I were in the operating room with a typical patient and the nurse wasn't able to get in the Foley, um, what is the typical Foley the nurse is? What is the size she's typically putting in, and what is the next step when the nurse says I can't get this in?
Yeah, sure. As you know, that's a common problem. The usual catheter is a 16 French Foley catheter. Difficult catheters, more often than not, as you've experienced, I'm sure, are on male patients, but occasionally you get a difficult catheter on a female patient. And my approach to that is, for a general surgeon, if there isn't a urologist available, is getting a history of the patient. Has the patient had previous urologic surgery, a previous transurethral resection of the prostate, or a previous prostatectomy? That's going to give you an idea as to what the most likely problem is as to why that catheter is not making its way into the bladder, bladder neck constricture or stricture formation or something like that.
Let's say there's no known history and the patient's already asleep. There's no scars down there to suggest there's no targets from previous radiation or anything, and
Sure.
we just suspect it's maybe a little BPH or something.
Sure. So how to get that catheter in?
Yeah.
The best option there really is, a lot of the nurses know this, but if it's a male patient without a urologic history, you really want to make sure you fill the urethra with a column of lubricant. And there's two ways to do that. The standard Foley catheter kit comes with a syringe full of lubricant, and it actually has a little tip, a tapered tip. Most nurses will kind of squirt that into the tray and just wipe the catheter with some lubricant, but it was really designed to be instilled into the stretched penis and put right down the urethra. So you're filling the urethra with a column of lubricant. Most catheters will then really slide right in at that point. If there's still some resistance, a coude catheter or an angled tip coude catheter, 16 to 18 French, 90% of the time will go in with that column of lubricant.
Okay, so instead of going to a larger or a smaller catheter, just use a coude of you said 16 or 18?
Yeah, generally speaking, you don't want to go smaller. You want to go bigger because the smaller you go, French size of the catheter, you're not going to have enough tension to really push through opposing lobes of the prostate, and that's usually the situation if they haven't had previous surgery. So what you want to do is you want to go 16 to 18 coude tip, which is a curved tip. The key is filling that urethra with the lubricant, and not just squirting that into the tray.
Right. Yeah, I've seen that done various ways, and I guess I hadn't realized the importance of filling the urethra. Good tip.
Yeah, when you look at that, you look at the syringe. The tip is actually tapered to be put into the meatus.
Okay, good. So another problem that comes up, or that we worry about a lot, is actually dividing the urethra during a case. Let's say I'm doing a sigmoid colectomy, and I divide the ureter, and I know that I divide it, and I see it, and let's say I cut it with an energy device like a harmonic scalpel or something. Sure. And the first thing I would do is hope that there's a urologist nearby, and if there weren't, and I were pressed to repair that, should I repair it? Should I stent it? Should I delay repair? What should I do? Let's say I am halfway through my case taking out the sigmoid colon. What should I do if I know that I divided the ureter?
Well, that depends really on the nature of the injury, and if it's a harmonic scalpel, you've come across it with energy, and you've completely transected the ureter. I'm going to assume that this is sort of at the pelvic inlet, at the area of the sacroiliac joint, the crossing of the vessels, perhaps. It really depends on the surgeon's ability and comfort level there. We experience this every so often in urology, since we do cover a number of satellite hospitals where we can't always be there, within an hour or two. Right. So If the surgeon is trained and is comfortable doing the reconstruction, that usually isn't the case, though. A distal ureteral injury like that, let's say it's at the level of the iliacs or distal to the level of the iliacs, like you would experience in a sigmoid colectomy, you're really not going to be doing an end-to-end anastomosis or a ureterostomy in that situation.
Okay.
You're just not going to get the length to be able to do that and be able to see and do that in a tension-free fashion. You can do a ureterostomy if you're in the proximal ureter, where you have enough length, you can mobilize a little bit of that ureter without devascularizing it, and spatulate it and do an end-to-end reconstruction over a stent. When you're talking in that area that we're talking about with the sigmoid colectomy, you really have to do what's called a ureteromesocystostomy, or essentially taking the ureter, the transected end, and replugging that into the bladder. But you have to mobilize the bladder to do that. And mobilizing the bladder would mean freeing up the contralateral superior vesical artery so you can bring that bladder over and doing a psoas hitch, potentially a Boari flap to gain a little more distance, because you want to make that reconnection to the bladder under tension-free. You put tension on that, that's going to stricture down. And the caveats are putting a stent in place. You've got to stent that. You have to do that tension-free, and then you want to place a closed suction drain, like a JP drain, next to that.
So that's probably something that you're not going to be talked through over the phone. Then, in other words, the hitch, the psoas hitch, is elevating the dome of the bladder, right? Okay.
That's correct.
So, yeah. So these aren't things.
So you're taking the dome of the bladder. You're essentially taking the dome of the bladder. You're making a transverse incision or oblique incision into the bladder, and you're bringing that dome up to the psoas muscle. Exactly right. So you can meet the cut end of the ureter. Most general surgeons don't really, in my experience, won't really do that. Right. So if we're not available, and it has happened actually, we get a call from a satellite hospital. We're not available for an hour to 2+ hours, and they're done with the case. We've actually had surgeons where they will ligate the proximal end of the transected ureter. If it's a pure transection, ureter is cut. We'll have them ligated either with a clip or with a silk suture. Get a suction drain in place, a JP drain, close the abdomen, and get the patient interventional radiology, and have a perc tube placed on that side. This way, you're at least draining the kidney. You're not going to deal with an ileus. You're not going to deal with a urine leak and a wound that doesn't heal, and then do a delayed reconstruction.
Okay. And you were suggesting that if you have a more proximal injury, you can spatulate and sew end to end.
You certainly can. Yeah, you just want to make sure that you free up enough of the ureter without getting into the adventitia. In the ureter, as you're probably aware, you can really mobilize that pretty far up, right up to the uretero-pelvic junction if needed. You only want to mobilize enough so that you have a tension-free anastomosis and to spatulate that ureter.
Okay. Yep. And what kind of suture would you use for an end-to-end repair?
An SAS. So, a non-tapered needle. I typically use 4O, 4O SAS or a 4O monochrome.
SAS?
And you would just... synthetic absorbable suture, something that's absorbable. You don't want to use permanent suture. So, vicryl or monochrome would be fine. Okay. Permanent suture in the urinary system is going to develop stone formation. So you don't want to have any permanent structures or sutures. And you have to make sure you stent it. You just stent across that and do a closure, primary closure, either running or simple interrupted. I do them simple interrupted with some 4 or 5O suture. And you make sure you've got to drain it. You got to get a JP drain alongside that. Okay,
great. What about a bladder dome injury? Let's say I was doing an elective sigmoidectomy for diverticulitis, and didn't realize that it was stuck to the top of the bladder, and ended up, just opening up a hole that's a couple centimeters wide in the dome of the bladder.
Sure. Well, that's an easy repair, and I think most general surgeons will give us a call, and if we're available, great. If not, they will do a 2 or a 3-layer closure. There are a couple different ways to skin this cat. There are some urologists that like to close the mucosa, and they'll close the mucosa with a 3O monocryl or 3O absorbable suture. and then run the detrusor muscle. Run the detrusor muscle. If there's any concern about leak, you can always do a Lambert suture on top and do a 3-layer.
Okay.
And make sure you maintain the catheter, a Foley catheter, for at least 7 days.
Okay.
The other thing you can also do very easily is just fill the bladder. Have one of the circulators go underneath and fill the bladder with some indigo carmine and saline, and you just make sure that your anastomosis is watertight.
Okay.
In 7 days, 7 days with a Foley catheter is usually all that's required.
Okay. And the if it's just a round hole, do you close transversely? Does it matter if you go vertically or transversely on the dome?
No, it doesn't really matter at all. The bladder is a very forgiving structure.
Mm-hmm.
If it's at the dome, you're very safe. You're away from the trigone. You're away from the ureters. So long as you have a watertight closure,
Okay.
Everything will be fine.
Okay,
Yep.
good. What other common calls do you get from general surgeons on
Thankfully, we don't get many
problems?
calls.
Oh, good.
We don't get many calls from general surgeons. I mean, generally speaking, general surgeons can handle almost everything. They're not used to, at least the ones we've worked with, in doing psoas hitches, ureteral neocystostomies, and they would certainly call us in for something like that. But it doesn't happen very often. Okay. When you look at intraoperative ureteral injuries, by far it's more common in gynecologic surgery because of the nature of the business. I mean, they're doing open or laparoscopic hysterectomies, and the ureter literally sits right there 2 centimeters away from the uterine vessels and the cardinal ligament, and also right underneath the infundibulate pelvic ligament. So they're common structures that are injured. Right. That's much more common.
Right. Okay. Great. Well, really appreciate you talking to us about common urologic problems for the general surgeon. I hope to talk to you again soon.
It's my pleasure. Thank you.
Mm-hmm. Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.